So last thing, if I remember correctly, we were talking about was systemic vascular resistance. A systemic vascular resistance or total peripheral resistance, remember, is the opposition to the flow of blood through our blood vessels. We learned that the smaller the blood vessel is, the higher the resistance is. And the very last thing we talked about was the very last bullet there. Vascular resistance is high. Only way to maintain blood flow is by increasing the pressure gradient, which is done by making your heart generate more pressure with each contraction. And we kind of left it off by saying this is unfortunately what happens when people have high blood pressure, which causes high vascular resistance, and their heart over time just wears out, and that leads to bad things. So with blood pressure in mind, let's go ahead and begin today really diving in on talking about it. I'll let you guys fill in the blanks, then we'll go through and discuss. All right, when your ventricles contract, and really mainly we're focusing on contraction of the left ventricle, they generate blood pressure. Blood pressure is defined as the hydrostatic pressure exerted by blood on the walls of a blood vessel. So in other words, it's the outward pushing of the blood on the walls of your arteries and veins, okay? And that's what blood pressure is. The three main factors that affect your blood pressure would be your cardiac output, your total blood volume, and your vascular resistance. Okay, and to kind of help illustrate and explain it, I can basically do it very simply. Actually, let's steal a different piece of paper. All right, so once again, the three different factors or things that affect blood pressure: cardiac output, total blood volume, and vascular resistance. Okay, basically, if we see an increase in any of those, whether it's increased cardiac output, that's going to result in an increase in blood pressure. Okay, if we reversed it and we said any decrease in cardiac output, we could say it decreases blood pressure. Now, remember from our last lecture, which you guys just had a test on, the two factors that affect cardiac output are heart rate and stroke volume. So if you alter your heart rate, you alter your stroke volume, those would influence your blood pressure. Okay. When it comes to blood volume, remember blood volume refers to the amount of blood that we have. And for those of you who are in anatomy, we were talking about blood this morning. We haven't really done that so much in this class yet. That'll be in our next lecture. Okay, but just about half of your blood is water, and therefore, if you alter your water level, you can alter your blood volume. Okay, if your blood volume goes up, so too does your blood pressure. So any increase in blood volume affects blood pressure, whereas any decrease in blood volume decreases your blood pressure. And this is what we're going to utilize hormones to do in order to affect blood pressure. Essentially, a lot of this will revolve around either retaining more water, peeing out less to help elevate blood pressure, or peeing out more water to lower your blood volume and therefore lowering your blood pressure. We'll get into that here this afternoon. Okay. And then the third factor that affects your blood pressure is vascular resistance. Remember, SVR is short for systemic vascular resistance. Any increase in that increases blood pressure, whereas any decrease in that decreases blood pressure. So it's a nice relationship. Hey, it's a proportional relationship, not an inversely proportional relationship like we've seen with like SVR and blood flow. And the proportional relationship means that if one goes down, the other one goes down, or if one goes up, the other one goes up as well. Okay. So those are the different and most easy ways to affect blood pressure. Okay. Now, if I jump ahead to the next slide, here's a more kind of sophisticated illustration of how to affect your blood pressure, which is labeled down here as MAP, which we'll talk about here in a second. Okay, but increasing cardiac output, okay, which we learned previously can be done through increase in heart rate and or increase in stroke volume. We learned, and you guys just had a test over this stuff. So you should know what increases your heart rate, what increases your stroke volume. Over here on the right, we're talking about increasing stroke or systemic vascular resistance will trigger increase in MAP. And this is what we left off kind of talking about in the last little bits of Thursday last week. The three factors that affect vascular resistance are blood viscosity, or the thickness of your blood, which doesn't really change in normal conditions, but can in cases like polycythemia. Blood vessel length, which we learned also doesn't really change from second to second, but can in cases of like obesity. What our brain and the medulla oblongata can most affect, though, is the radius of our blood vessels through vasoconstriction and vasodilation. And if we're talking vasoconstriction, this vascular resistance goes up, which is what makes your blood pressure go up. So they don't directly talk anything here about blood volume, but if we go all the way up to this point, affecting venous return is blood volume, and that ties into stroke volume. So it's kind of off by itself, like it is listed here on the previous page. As we can see here in our graph here on this previous page, which is measuring the pressure in the various blood vessels of our circulation. We start at the aorta, which is the blood vessel that leaves or receives blood when it leaves the left ventricle. Okay, systemic or systolic and diastolic blood pressures are much highest there, and as we travel down farther away from the left ventricle, it gets less and less and less. Okay, and the reason is because, remember, we always want to return blood to the heart after we pump it out. So we have to establish a pressure gradient where it's progressively going from higher to lower to lower to lower. And your vena cavas are the last blood vessels that have blood before it comes back into your heart. Okay. We learned in our previous lecture the term systole, diastole, which relate to things going on with the heart. Okay. We have systole, which we learned is contraction of the heart, whereas diastole is relaxation. And those two periods of time associated with the heart affect our blood pressure. And by that, I mean, there are periods of time in our blood vessels when the pressure is higher because the arteries are receiving blood that's being pumped out of the heart at a higher pressure. That's your bigger number. And then the lower number is the pressure in the arteries during diastole or during the relaxation phase of the heart. That would be the lower number. So like when you say 120 over 80, okay, the 120 would be systolic, diastolic would be 80. Okay, if you are taking a math class and you're calculating a mean, you're taking an average of numbers. Okay, so mean arterial pressure is taking those two numbers and creating one number. Okay, and it is therefore the average blood pressure in the arteries. Okay, it is roughly a third of the way between DBP and SBP, which might be kind of shocking. You would probably think, for example, if your blood pressure was 120 over 80, that, you know, you add those two together, you divide by 2, which is how you calculate averages. We know you add all the numbers up, divided by however many of the numbers there are. Okay, in this case, there's 2 numbers, so you add those 2 numbers up, divide by 2. We would think mean arterial pressure would be 100 because that's right there in the middle between 120 and 80, but that's not actually the case. Your mean arterial pressure in that case is closer to 90, 93, something like that, if I remember off the top of my head. I haven't ever, or I haven't done the calculation in a long time, which you can see the formula for that at the bottom of the page. Not something I'm going to ask you to know. And you might be wondering, well, why isn't it 100 right there in the middle between 120 and 80? And that's because you actually don't spend equal times in systole and diastole. In other words, your heart actually spends about 2/3 of its time in the relaxation stage, whereas it only spends about 1/3 of the time in the contractile stage. So your arteries and your blood vessels are only in the systolic phase about 1/3 of the time, whereas 2/3 of the time it's diastolic. So that's why it's closer to the diastolic number and farther from the systolic. Now that's going to be all dependent upon making sure you understand this. This will be all in a case of being in a resting condition. Whereas like if you're exercising and your heart's beating more rapidly, this ratio of about a third of the way between the two numbers is not actually accurate anymore because we don't have that 2/3, 1/3 balance. It's a little bit more 50-50. So that's blood pressure. Okay, I wish we could do a physical lab where we could all get together and take blood pressures with each other. It's a lot of fun and interesting. You can do a lot of different things to affect blood pressure, and I'll get into that a little bit later in the lecture. Now, looking once again at this illustration, it's pretty complicated, but it's very handy. It's got everything that we really have talked about or will talk about, which includes this concept of venous return that I kind of introduced a little bit about in our previous lecture when I was talking about stroke volume. Let's talk about venous return now in a little bit better detail. Venous returns, name tells you exactly what's happening, the return of blood back by way of veins to your right side of the heart. Several factors affect and promote venous return, okay? One of which is that pressure gradient that exists because of the pressure generated by constriction of the left ventricle, okay? And then as that pressure progressively falls and falls and falls, we're establishing pressure gradient that helps that blood return back to the heart, okay? When it gets into the venous circulation, that pressure gradient doesn't have to be tremendous. There's only about a 16 millimeter mercury difference between our smallest veins, known as venules, and the right ventricle, and that's sufficient enough to promote venous return to the heart. So the venous pressure gradient is going to help promote venous return. Okay. Besides the heart, two other mechanisms help pump, and notice here we have that word pump in quotations. Okay. One of which is illustrated here in the top figure, what we call the skeletal muscle pump, which helps milk the blood upwards and towards the heart. Okay, it's important to understand that blood inside our body is subject to the force of gravity, just like fluids are outside the body. You know, we could think about like what would happen to my glass of water here if I were to tip it sideways. That water is going to fall to the ground thanks to the force of gravity. Okay. Well, the gravity is affecting the blood inside our body just like it would be that water. And so what I'm getting at is the fact that the natural tendency, thanks to gravity, is for blood to want to stay down in your feet, especially when you're upright and you're walking and you're kind of pounding that pavement, as they say. Okay. That is not a good situation. What we do not ever want is blood staying in your lower body, and your skeletal muscle pump helps do that. It basically, think of it like milking a cow. I'm sure you've all seen videos and movies, that kind of stuff, where people milk cows, or maybe you've actually done it, where you squeeze on the udder, and that's what your muscles do when they contract and relax. They squeeze when they contract, and then when the muscles relax, they allow the blood to continue forward. And thanks to those venous valves that I talked a little bit about the other day, they prevent the blood flowing backwards after that, contractile squirting process takes place. So it's only going to allow the blood to go forward, just like what we talked about with the valves inside our heart. So venous valves and the skeletal muscle pump help each other out, as does the other important pump, what we call the respiratory pump. I don't have a picture of, but it utilizes pressure changes in our thoracic and abdominal cavities when we breathe. Okay, like I was kind of talking a little bit about this last week, in order for air to come in and out of our lungs, we change the pressure in our chest or thoracic cavity. Okay, to take a breath in, we drastically drop the pressure in our chest and around our lungs. And in doing so, that actually will drop the pressure in that cavity below pressure in the abdominal cavity. And so once again, this establishes a pressure gradient that draws the blood up from the abdomen into the thoracic cavity or up into the chest so that we can get that blood back into the heart. And then finally, the final structure, the final method in which we promote venous return is through that process of venoconstriction, where we can, contract the smooth muscle in the walls of the veins. And we got into that a little bit the other day when we kind of first talked about the structural makeup of veins and that hemodynamic factor called capacitance. If I go back to, once again, this page, they've got here for increased venous return, the four things that they've got: venoconstriction, respiratory pump, skeletal muscle pump, but they also include increased blood volume, which, is not something that is a kind of real short-term way to promote venous return. They don't include the pressure gradient, nor do they talk about venous valves, but those are obviously important. So that's venous return. Our next hemodynamic factor is the velocity of blood flow. And when I'm talking velocity of blood flow, I'm talking about the speed at which the blood is flowing through our various arteries, capillaries, and veins. What we see is another one of those inverse relationships, which states that the speed of blood flow in centimeters per second is inversely related to the cross-sectional area, or in other words, like the amount of blood vessels. And what we see, therefore, is where cross-sectional area is the highest, where we have the most types of blood vessels, our capillaries and our venules, the speed at which that blood is flowing is the lowest. The velocity is lowest. So if it's high cross-sectional area, velocity is lowest. Okay. The importance of this is to aid in exchange, which takes place in the capillaries. Remember, the entire goal of our cardiovascular system is to deliver oxygen, nutrients, and remove waste and carbon dioxide from tissues. Okay, deliver nutrients to, remove waste from. Okay, performing what we call capillary exchange. Okay, remember I said capillary exchange is like where the magic happens, and I was first taught it this way, and this is the way I always taught it. My instructor at K-State that taught me this had this analogy. If you're not familiar with Manhattan, in the town of Manhattan, there's a bar district close to campus where a lot of kids go to, drink some beers and have some fun. That bar district is called Aggieville. And before the advent of like food trucks that they have there now, it was common for students to get a ride from Aggieville once the bar's closed to McDonald's, which is about halfway across town. Okay, so you hop on your ride and you're on your way to McDonald's, and you're very hungry, so you're driving at a fairly rapid rate, or hopefully you're not driving, but you're in a car that somebody else is driving, and they're going at a pretty good rate, kind of like what your blood does through the arteries. Once you get to McDonald's, is it possible to drive through the drive-through at that 30 miles per hour? Hopefully not. Okay, you wouldn't be able to pay for your food, and more importantly, you wouldn't be able to get your food. So you have to slow down. In some cases, come to a stop for a couple minutes. Obviously, that's not what our blood does, but it goes very, very slowly, where we are doing the exchange of goods. Oxygen and other nutrients are leaving the blood to go to the tissues. CO2 and other wastes are coming into the blood. And then just like when you get your food and you're able to leave the drive-through, then the velocity can pick back up. So that's the analogy that I always use, and it seems to be pretty good for visualization purposes. All right, now that we've kind of talked about the different hemodynamic factors, I want to talk about how we control our blood flow. And we'll start by talking about the cardiovascular center, the CV center that we previously mentioned in our last lecture. Previously, we learned that cardiovascular center in our medulla oblongata helps regulate heart rate and stroke volume, so therefore it helps regulate cardiac outputs. It also controls neural, hormonal, and like negative feedback systems that regulate our blood pressure and the flow of blood to specific tissues. So we're going to kind of focus in on regulating blood pressure, especially here in our next couple slides. Within our cardiovascular center are groups of neurons that regulate heart rate, contractility of ventricles. Those neurons would be what we call the cardiac center. You also have what we call the vasomotor center, which is what affects your blood vessels diameter and thus most directly influences your blood pressure through either vasoconstriction or vasodilation. And that vasomotor center, which is what I was just talking about, controls blood vessel diameter by causing constriction dilation. Okay. What we talked about in our last lecture is this bullet here. The neurons of the cardiac center in our medulla can either be cardiostimulatory. In other words, that's these cardiac accelerator nerves of the sympathetic nervous system that increase heart rate and contractility. Whereas in the case of the inhibitory ones, the cardioinhibitory ones are the vagus nerves that decrease your heart rate and really don't do too much to contractility, but that therefore by decreasing heart rate decreases cardiac output. Okay. Once again, remember, we aren't going to produce any responses without first having an input, providing us with a reason to actually elicit a change. And so what we're going to talk about more so now here in this lecture are the inputs. Okay, our cardiovascular center receives input from higher brain centers, which I'll talk about here in more in a second, but also from three major sensory receptors. We're not going to really talk too much about proprioceptors, but remember those are within your joints, your muscles, and your tendons, where they monitor those movements of your joints, tendons, and muscles. What we're going to talk about on the next slide are the reflexes that involve your baroreceptors, which are found monitoring your blood pressure. So basically, they're monitoring how much of a stretch the blood vessels are under. And then chemoreceptors, which monitor chemical concentrations. And it's three major things. We're measuring how much hydrogen ion, carbon dioxide, and oxygen is in the blood. Okay. So those provide input to the cardiovascular center. But we can also, like I said, involve higher brain centers like the cerebral cortex, the hypothalamus, or as we know it, the limbic system, the emotional brain, which explains why, not only like if you're nervous, does your heart rate go up, but so does your blood pressure because of all the different mechanisms that fight or flight nervous response triggers. So let's talk about those two baroreceptor, chemoreceptor reflexes. These two reflexes I actually mentioned a little bit about in our previous lecture. I told you guys we would talk about them here in this one. Well, now we're at that point. And these two reflexes are how the nervous system regulates blood pressure using negative feedback loops. Okay, and so if we're talking negative feedback, we're going to say that, for example, if blood pressure drops, we're going to try to make it go back up since we're going in the opposite direction, which is how negative feedback works. First reflex is called the baroreceptor reflex because it involves baroreceptors, which I just mentioned are the ones that monitor pressure changes and stretch in the walls of our blood vessels. We don't have baroreceptors throughout the whole body. Where we have them is pretty darn close to the heart. Places like the aorta, which is just above the heart, internal carotid arteries up there in your neck, and other large arteries in your chest and neck. Okay. They're going to send impulses to the cardiovascular center to directly help regulate blood pressure. Okay. The reflexes are illustrated here with our next two bullets. Okay, one where the blood pressure falls, one where blood pressure increases. So when blood pressure falls, our baroreceptors are stretched less. That's because the blood vessels are stretched less. There's less pressure pushing out. And that means there's going to be a slower rate of impulses sent to the cardiovascular center. Our cardiovascular center decreases parasympathetic stimulation and increases sympathetic stimulation as a result. Okay, and in doing so, that means your heart rate's going to go up, which once again, any increase in heart rate means that your blood pressure is going to go up, because that's, any increase in heart rate is going to help elevate cardiac output. And as we said, any increase in cardiac output increases blood pressure. So that's how we can affect blood pressure, but also we can directly vasoconstrict the arterioles of our body, which will directly increase blood pressure as well. Okay, so in this case, both instances, a change to the heart and a change to the blood vessels, known as arterioles, results in an overall increase in your body's blood pressure. When blood pressure increases, we basically do the opposite, and it's because baroreceptors are stretched more, therefore a faster rate and more often or more action potentials are sent to the cardiovascular center. And instead of activating the sympathetic, decreasing the parasympathetic, we do the opposite. So we increase parasympathetic, decrease sympathetic. This causes a decrease in heart rate, which therefore decreases cardiac output. And as we've already said, any decrease in that cardiac output lowers your blood pressure. We're also going to, instead of vasoconstrict, we're going to vasodilate, which helps to lower your SVR. And in doing so, any decrease in SVR also lowers blood pressure. Okay. Looking here on the next page, we have an illustration on the left showing you some of those baroreceptors located, in this case, in the aorta, up and in the carotid sinus, up in the neck. Okay, they provide the input signal to the cardiovascular center. Whether it's because blood pressure's gone up or whether it's gone down, we don't really care. If the blood pressure is gone down, what we need to do is make our blood pressure go up, and that occurs because of two things. We increase nerve signaling to the SA node, makes the heart beat more fast, cardiac output goes up, and then we also promote vasoconstriction. Okay, if our blood pressure goes down, we want to, or excuse me, if our blood pressure is high, we want to do the opposite. We want to make it go down, which means in this case, we're going to send signals out through the vagus nerves to slow down the sympathetic, increase the parasympathetic, so your heart rate goes down, and we'll also vasodilate the blood vessels known as arterioles. Over on the right is a feedback loop showing you what actually is taking place with a decrease in blood pressure. And I was just walking you through it. So the baroreceptors are stretched less signals sent to the cardiovascular center, but the cardiovascular center responds by increasing sympathetic and decreasing parasympathetic stimulation, which means your heart rate and your stroke volume will go up, therefore increases in cardiac output go up. We'll also send out signals from the adrenal medulla to release epinorepinephrine to help with this. And we will also vasoconstrict your blood vessels to increase your SVR. And here we can say we bring it back up, which is an example of negative feedback. Unfortunately, your textbook doesn't have an illustration or anything for the chemoreceptor reflex, so I'll just have to explain it without any pictures. Chemoreceptors are the receptors that are going to monitor chemicals in our blood, okay? Hence the name chemoreceptors. We have them kind of in the same areas in your carotid sinus and aortic arch, so up in the kind of upper chest into the neck area. These detect three things: hypoxia, which is low oxygen in our blood, hypercapnia, which is high carbon dioxide levels, and acidosis, or high hydrogen ion concentrations in the blood. And any one of those or all three of those are going to result in signals being sent to the cardiovascular center. And as a response, the cardiovascular center will increase sympathetic stimulation to your arterioles and veins, causing them to vasoconstrict, which therefore increases your blood pressure. And so chemical concentrations can elicit changes to blood pressure. And something that's really cool is you can actually purposely alter your blood pressure by affecting these three things just by doing something simple, which is holding your breath. And if you hold your breath, we're not going to be breathing in oxygen, so your oxygen levels will go down. If you're not exhaling CO2, your CO2 levels will go up. We haven't talked about this yet, but we will here for several different lectures here in the next few weeks. If carbon dioxide levels go up, carbon dioxide will join with water and become an acid, and that acid is known as carbonic acid, which results in the formation of hydrogen ions. So these three things can occur when you do something simple like hold your breath. So like I said, if we could do a physical lab together, we would do a blood pressure reading where we're doing our best to hold our breath for that amount of time. It might be kind of hard to get that blood pressure read in that time before we have to breathe again. But it would be enough probably to elicit a change. The great thing about these three things in this reflex, these same receptors, these same conditions, hypoxia, hypercapnia, acidosis, are going to be discussed here again in our next unit, because these are what send information to the respiratory center in your brain, which is what adjusts your breathing rate. So in other words, these three things are what affect how often we breathe. And so we'll be getting into that again here in just a little bit, not today, not tomorrow, but here in a few weeks. Okay, so that's how your nervous system can trigger changes to blood pressure. We also have several hormones. Some of them are hormones we've talked about before. Some of them are more brand new, but these hormones can have effect on your blood pressure and the blood flowing from your heart to various places. They do so by kind of one of three things, or in some cases, a couple of these three things, either by altering your cardiac output, or by changing your SVR, or just by changing your total blood volume, which is a little bit more difficult and a little bit more of a long-term way to regulate your blood pressure, because you can't, change your blood volume in a short amount of time. It takes time to either pee out more water, or pee out less water, and to, engulf some when you drink it, and eat foods that have it in it. Okay. So it includes the following hormones. The renin, angiotensin, aldosterone system I'll talk about first is going to involve a very complicated series of events. Kind of introduced this to you guys back in the endocrine lecture, where we have influences occurring with the kidneys, which is where we produce the enzyme renin. Whenever our blood volume falls or blood flow decreases. Angiotensin converting enzyme, which is going to be, I believe, in the lungs, which activates the hormone angiotensin 2. And then aldosterone, which is produced by our adrenal cortex. So you've got quite a few different organs going on. Okay. So what does this whole system or mechanism do? Well, once again, we release renin when our blood volume falls or blood flow to the kidneys decreases. Okay, so in other words, the kidneys are detecting a drop in blood pressure. So what do? They want to raise it back up, and they do so by performing vasoconstriction. Okay, and so this makes blood pressure go up in and of itself. But it also triggers the release of aldosterone, which, if you don't remember, is nicknamed the salt retaining hormone. And that's because it helps us retain salt. In other words, we reabsorb sodium ions, and in doing so, if we retain salt, we're also going to retain water. Therefore, our blood volume goes up. And as I said earlier today, and I wrote it on the piece of paper, any increase in blood volume results in increases in blood pressure. So this is a complicated series of events. And if you just want to simplify things, if you wanted to kind of over off here on the side, just, say equals increase in blood pressure. It's kind of the end result. Okay. Anybody ever heard of ACE inhibitors before? Yes, no, that's been them. ACE inhibitors are a type of drug that inhibit this enzyme. Okay, and people take ACE inhibitors when they have high blood pressure because it prevents angiotensin converting enzyme from having this action, producing angiotensin 2. So none of this stuff occurs. No vasoconstriction, which raises blood pressure, decreases the secretion of aldosterone, which we just learned increases blood pressure. So it's a very effective drug for preventing even higher blood pressures. Okay. Epi and norepi, which we know by now at great lengths. We've talked about these two hormones. As we know, epi, it's also can be described as adrenaline, and norepinephrine as noradrenaline released by the adrenal medulla whenever we have that fight or flight response. So we know exactly what takes place here. They trigger increases in cardiac output by both increasing heart rate and contractility. Okay, any increase in cardiac output, as we've said, increases blood pressure. They also produce vasoconstriction, and I've said it before like this, which is kind of misleading, but I say, I told you guys that epi nor epi produce widespread vasoconstriction. Well, that's not 100% true. They really only vasoconstrict some of the blood vessels in the body, a good number of them for sure, the ones that feed our skin and the abdominal organs. But remember, when we are in a fight or flight response, we need to increase the flow of blood to your skeletal muscle and your cardiac muscle, the things that are working, whether it's by, letting you run or fight or whatever, and then pump the blood. That's why we need to increase the flow of blood to the heart. So in that case, we don't vasoconstrict those arterioles, we vasodilate them. Okay, but the vasoconstriction of everything else is going to result in increases in blood pressure. So kind of just like what you did over here, if you want to, for epi nor epi, if you want to, put in parentheses or equals to increases in blood pressure. Antidiuretic hormone, as we previously learned, is the hormone released by the posterior pituitary, but made by the hypothalamus in response to dehydration or decreased blood volume. And it is a hormone that does the opposite of what a diuretic does, which makes you pee a whole bunch. So antidiuretic hormone helps you retain your water, and therefore your blood volume will go up. That'll alone cause increases in blood pressure. But more of a short-term way to increase your blood pressure, it promotes vasoconstriction, and in doing so, that increases blood pressure. If you don't remember, I told you guys this a few weeks ago when we talked about this hormone. The other name for it is vasopressin because of what it promotes, which is vasoconstriction. Okay. And so this one equals increases in blood pressure. So these first three big bullets here are all telling you we have hormone or hormones that increase your blood pressure. The last one, called atrial natriuretic peptide, is a brand new hormone to us. Okay, although if you think back to that lecture, the endocrine system, there was that slide where there was a table of organs and hormones that some of those organs produce. A and P was on that table. Told you we would talk about those things later in the semester. Well, here is one of those times. Atrial natriuretic peptide is named its way that it is because it's produced actually by the atria of the heart. And its job is, and it's the only one that does so, lower your blood pressure by promoting vasodilation and promoting the loss of salt and water in urine, thereby reducing blood volume. Okay, so it makes you pee more water and salt out. So essentially, atrial natriuretic peptide does the exact opposite of what antidiuretic hormone does. Now, if those things didn't make any sense for you, maybe table 121.2 will help you understand exactly which hormones increase versus which hormones decrease your blood pressure. And then I like the table because it breaks it down by how, whether it's influencing cardiac output, influencing vascular resistance, or by altering your blood volume. And then over on the right, it just shows different ways to increase your blood pressure, changing your blood volume, which means, basically either retain more or less water, change your heart rate, change your stroke volume, either an increase in one or both of those, as we know, alters cardiac output, and the increase in cardiac output increases blood pressure. Blood viscosity, that one's the tricky one because we really can't just trigger our blood to become thicker or thinner in a short amount of time. That's more of a kind of an accidental type thing where, like we talked about, blood doping and that kind of stuff, and then peripheral resistance increases or decreases will change your blood pressure. We're talking increases in blood pressure, it's due to SVR increases, which is through vasoconstriction. So just a couple of different illustrations and whatnot to kind of explain what's going on. There's one last way to affect your blood pressure, and this is what our individual capillary beds utilize, what we call autoregulation, which we've seen this prefix auto a couple of times here the last couple of class periods. We first thinking back to last week, talked about autorhythmicity, which relates to action potentials in the heart. I mentioned it at the time. If you don't remember, auto is a prefix that means self. So autoregulation means self-regulation of blood pressure. In each capillary bed, so like, for example, in the capillary beds of your stomach, or in the capillary beds in your heart, in the capillary bed of your brain, or in your skeletal muscles, we can have local specific changes occurring there that can cause vasomotion. Vasomotion being either vasoconstriction or vasodilation. So autoregulation is this ability of our tissues to automatically adjust its blood flow to match its metabolic demands. So it can change the width of the blood vessel by either promoting vasoconstriction or vasodilation in order to increase or decrease blood flow through that tissue. Okay. Examples here for when we exercise, the demand of oxygen and nutrients as well as removal of waste goes way up when we exercise, especially in our heart and skeletal muscles. So in this case, what we are going to see is, for example, the blood vessels within our skeletal muscles, changes are going to occur that we will want to see vasodilation, more blood flowing through. Same thing we see like up in the brain, and this is a really cool thing, and this is how kind of scientists figured out what parts of the brain do what. Okay. Blood flows to specific parts of the brain during different mental and physical activities, i.e. like when our blood flows to our motor speech areas when we talk. Okay. There are two types of stimuli that cause autoregulatory changes in our blood flow. Those that are physical in nature and those that are chemical in nature. Okay, the physical changes include temperature alterations. Okay, warming a tissue up promotes vasodilation, whereas cooling causes vasoconstriction. Using that same example we were just talking about with skeletal muscle exercise, what happens to the temperature of muscles when we exercise? Does it go up? Does it go down? Does it stay the same? It goes up. We just talked about, thermogenesis is something that our muscles have, right? The production of heat. Okay, more heat means that the muscle gets warmer, and warming helps promote vasodilation. That's fantastic. Okay. The last physical change involves what we call a myogenic response, which means it contracts more forcefully when it's stretched and it relaxes when stretching lessens. Okay. Looking at the next page, we kind of show what takes place here. We're showing an increased stretch due to an increases of arterial pressure triggers the opening of calcium channels that allow calcium in. Okay. If there's an increased stretch, we contract more forcefully, and it's because this calcium that comes in is going to involve binding to troponin, shifting and tropomyosin and all that wonderful stuff with the thick and thin filaments that we've learned about before. Okay. This is what helps us flow blood through an arterial, like in our kidneys, when blood pressure outside the kidneys is drastically changed so that we can continue to allow the blood to flow at a kind of normal constant rate. We're going to talk about what we call the myogenic mechanism, which involves this stuff here in a few weeks when we start talking about the formation of urine. So we'll look back on this and talk about it again. Chemicals that can either vasodilate or vasoconstrict are produced in our body by different types of cells. Those cells include white blood cells, platelets, smooth muscle fibers that are, the actual muscle that helps constrict or dilate, macrophages, which are white blood cells, and even the cells that line our blood vessels called endothelial cells. I do actually want you to know which chemicals are vasodilating and which ones are vasoconstrictors. Those that promote vasodilation include potassium, hydrogen, lactic acid, adenosine from the breakdown of ATP, and nitric oxide, which is a hormone we've touched on a time or two before. Those that vasoconstrict include thromboxane A2, superoxide radicals, serotonin, and endothelins. We don't really talk too much about most of those, but we will mention actually thromboxane A2 here in our next lecture when we talk about blood clotting, because this is a chemical that we release when we want to stop bleeding so much. Okay, and then that's what this figure on the right is showing you. We've got chemicals on the right that promote vasoconstriction, chemicals on the left that promote vasodilation. All right, I'm gonna stop here because we are out of time. We're gonna just kind of pick up here. I didn't finish the lecture like I was hoping today, but that's okay. We'll finish up pretty quickly on Thursday and just keep on moving on in to our next lectures at that point.